This is our third annual um, Canadian Cardiac Sarcoidosis Symposium, and Mustafa initiated the first one, and we actually had it in person, the first one in Vancouver, and then we had COVID, and nobody has in-person meetings anymore. But it was a wonderful meeting that one.
I'm sure. I mean, I love the topic.
Yeah,
Uh, well, I guess we can wait till everyone's plugged in, but I think the real issue with this is anybody who says they know what they're doing in this field 100% of the time, you know, every day I puzzle. I've got a case I'm thinking about right now that I can't quite get my brain around, and that's just happens to be today. But that's every day, I think, for most people who want to take this on.
yes, yes. Yeah. That's a curse but a blessing, because I always, oh, I'm sorry, we're at the edge of our knowledge and we're just going to make it up from here. Uh, so,
Yeah.
Mustafa, did you want to kick off?
Absolutely, I would love to. I think we have 22 people on right now, and I think might as well get started. So thanks everybody for joining, and thank you to David and the rest of the organizers for putting this on. As always, it's always nice to hear new people's perspectives on cardiac sarcoidosis. So we'll start off the session with Dr. Anthony Aizer. He's a associate professor at the NYU Grossman School of Medicine. He's an electrophysiologist specializing in advanced ablation techniques for AFib, atrial and ventricular arrhythmias. We won't hold that against you, Tony. I'm a heart failure specialist. And his research focuses within cardiac sarcoidosis, and he's been on and a lot of interest on risk stratification and ventricular arrhythmia management in cardiac sarcoidosis. And so with that, he's going to be discussing management of ventricular arrhythmias and cardiac sarcoidosis. So very much looking forward to this talk, Tony. Thank you for doing this.
Well, thank you for that very nice introduction, and also thank you for this invitation. I was saying I really love participating in these talks, and all kidding aside, one of the best things about doing cardiac sarcoid arrhythmia management is you work with the heart failure team, and you learn a lot about their perspectives on what's going on and trying to come up with a great therapeutic plan for your patients. So with that, let's get going. I guess I have a few disclosures, which you can see there, mostly related to clinical trial work. All right, so, what are we going to try to cover, right? So let's talk about what are the prognostic implications of ventricular tachycardia in patients with sarcoidosis. Let's talk about the role of inflammation and fibrosis when trying to figure out what is the appropriate strategy. And with those two pieces of information, try to recognize when to choose different treatment approaches based on clinical presentation. Okay, so let's start with the prognosis. It's always important to recognize when we talk about this group of patients with cardiac sarcoidosis, there's just an enormous spectrum of the disease. It's almost like saying a patient has coronary artery disease. So having said that, if you try to look at how these patients do, because it's a relatively small group, there are some data going back, now 7 or 8 years. This is basically a registry of about 100 patients or so. And they looked at various risk factors for survival in these patients, looking at transplant-free survival, just to be clear. And as expected, ejection fraction heart failure class remain significant predictors. But if you go on to look at multivariable models, it's actually quite distressing within a multivariable model, meaning that there's been adjustment for this. The risk factor for dying, the odds ratio is about 7.2 increase versus other patients with cardiac sarcoidosis without VT. So this is really a very important marker to help you understand that these patients need a significant amount of attention, not just at the moment of their ventricular tachycardia, but in terms of their prognosis overall. All right, there are some really nice guidelines, which, not surprising, Dr. Birnie led these efforts, which have gone back a little bit now, and probably will need some updating as more data comes along. But this is mostly about the utility of a defibrillator. And I'm not going to spend too much time in this talk covering this, but it's a complicated topic. I think what's important to recognize is that there is a lot of flexibility in the guidelines, recognizing the heterogeneity of the patients, right? So there's a lot of things where ICD can be useful, ICD may be considered, and there's a relatively small group where it's pretty clear ICD is not recommended, and yet they should still be followed. So the traditional indications, of course, still apply. There's some increasing complexity, in particular for patients with heart block who are going to need a pacemaker. There seems to be a lot of data support that they should probably get an ICD in this cohort. And then there's also important things to understand that are significant prognostic markers, which is one, the degree of late gadolinium enhancement. Two, if you remain unclear, there is utility to program ventricular stimulation to assess for the provocability of sustained ventricular arrhythmias, and then also symptoms like syncope. So putting this all together, it should always be remembered, if you're really concerned about sudden death, the initial therapy needs to be protection with ICD for these patients if they're at high enough risk. Okay, this is also, I believe, a paper from Dr. Birnie. That's a very nice review in JACC about sort of an overview of the way that this disease presents itself and why it's so complicated, which is that you can basically have small little patches, which may explain your heart block patient who apparently on sort of baseline echocardiography looks normal and you're not really sure why. You can then have extensive septal scarring. You can have septal and lateral wall, which is a pretty common presentation for a lot of patients. And then some patients really have extensive disease throughout. And this is critical to trying to come up with treatment plans for patients. When you have ambiguous other data points, understanding the extent of fibrosis for this patient is very important because it seems to predict outcomes, both sort of macro outcomes like survival, incidence of VT, but also sort of like smaller predictive things like what is the mechanism of the problem that the patient has. The only way to get this answer really is with an MRI, right? So yeah, echocardiograms give you some general data about where fibrosis might be, but I think most of us recognize at this point just how important MRI can be to figuring out both the prognosis and the therapies for these patients. So this is usually done with late gadolinium enhancement for fibrosis and then sometimes T2 imaging for edema, which we can talk about in a little bit. Whoops. But you can see in this patient, this is an example of a patient with pretty extensive fibrosis in multiple areas, extending down. So this is sort of a classic patient, and this is a very large burden of fibrosis in the setting of sarcoidosis. And this will really change your management of a patient and help to explain some of the problems that you may find. So what to know about fibrosis? So, fibrosis in general, the most common arrhythmia that it sets up for is reentry. So as we're trying to figure out therapies, and what electrophysiologists typically do is they put together a constellation of diagnostic information, including EKGs, history, imaging, and say, okay, what pattern does this represent, and what is the underlying arrhythmia mechanism, right? So if you're not an electrophysiologist and you're trying to figure out why did this doctor choose sotalol, or why did this doctor choose flecainide in a patient, it all comes down to what is the underlying mechanism, right? So, and those fall into three categories: automatic arrhythmias, triggered arrhythmias, and reentrant arrhythmias. So the thing about fibrosis is the setup for reentry, right? And reentry is basically two sides of a circuit with some area of slow conduction. This is a classic picture by Bill Stevenson, one of my favorite electrophysiologists and people. And it basically shows, and this is for scar VT, but it applies in a very similar way to patients with sarcoidosis, that when you see that LGE, late gadolinium enhancement on MRI, that they are going to likely have reentry as a mechanism for their ventricular tachycardias, and your therapies need to be directed at this underlying mechanism. Now, here's the thing about sarcoid. It gets very messy, right? So because there are these patches without homogeneity, you can have a lot of different circuits, right? Here's one circuit, then here's another circuit, here's a figure of 8 circuit, and all these things end up having different ventricular tachycardias, different patterns on EKGs, different rates, different hemodynamic implications, and also therapeutically require multiple targets. So this is often a very challenging situation in patients with cardiac sarcoidic fibrosis. Okay. Now, it's also important to recognize that patients with cardiac sarcoidosis won't always come in with very regular looking monomorphic VT of reentry. Sometimes they'll come in with polymorphic or pleomorphic forms of ventricular tachycardia. And there's been a lot of work on this in general to try to explain these things. And it's often felt to involve the His-Purkinje system as a mechanism for sort of variable areas of reentry or even focal activity and triggered activity using the Purkinje system. They tend to present with these types of abnormal heart rhythms that are not monomorphic, tend to be more rapid, frequently recur acutely after you treat them, let's say with cardioversion, and frankly can be quite lethal. So what's important to recognize that this is a subset that may more frequently show up in patients with cardiac sarcoid, and when the His-Purkinje system is involved, which tends to be along the septum, and when there's inflammation involved. So if you see these types of patterns in your cardiac sarcoid patients, when they show up, you always have to wonder about inflammation and sort of where is the substrate coming from. Okay, so with that background, you know, what is the data on ways to treat these ventricular tachycardias? So there has been some data comparing sarcoid ventricular tachycardia ablation to other forms of cardiomyopathy and their outcomes. And frankly, it ain't great. You know, this is the survival free from recurrent VT, and it's at the bottom of the heap, which is a testament to the substrate, right? So the substrate is very challenging in patients with cardiac sarcoid because of those multiple areas of involvement. And frankly, often they're deep within the myocardium and not so accessible by traditional ablation techniques. This has been supported in a much larger study. This is around, I think, 160 patients, and it's more of the same. You know, right? VT recurrence, highest in patients with cardiac sarcoidosis compared to these other forms of non-ischemic cardiomyopathy. Okay, so that's important to know when you're trying to decide what to do for a patient, but it does not present the data on what's the alternative in terms of antiarrhythmic therapy. So we'll get to that in a little bit, but there's also some work to try to understand who within that sarcoidosis group does better with ablation versus worse with ablation. And this is initially a small study, I think of about 17 or 20 patients that looked at complete success, meaning no VT recurrence, partial success, meaning a significant reduction, and then failure, complete recurrence. And they split these patients based on whether or not they had concomitant inflammation from sarcoid. So how do you make that assessment? Well, the way it's most commonly done now at most centers is with a PET scan, looking at an FDG PET scan. So these patients underwent PET scan and they were categorized accordingly. And the group A were the patients who had not just fibrosis, but additional ongoing inflammation on PET scan. Group B was the group of patients that did not have any inflammation. And there's a significant improvement in ablation outcomes if there is not ongoing inflammation at the same time. This was a relatively small study, and then this was looked at again in a much bigger group of patients, and essentially they found the same thing, right? So yes, post-ablation, the amounts of therapies went significantly down for the vast majority of patients when they underwent ICD ablation, or underwent VT ablation, excuse me. If you tried to separate them out, the patients that had no inflammation on PET scan had a far lower rate of recurrence of VT compared to the patients who had ongoing inflammation. So that's a really important thing to consider when you're trying to decide how to handle this. Now, the questions arise, which I think are reasonable, which is, why is it less successful in the groups with ongoing inflammation? And you can imagine a couple different things. It could be something intrinsic about the patient, that inflammation itself predisposes to recurrence, maybe because the substrate is changing, you can imagine, and what you ablate on Monday may not be what's relevant on Tuesday. But another possibility, which I think Dr. Birnie, again, has done a great job exploring, which is, well, is it that the therapy that we are giving patients from inflammation, is it possible that this is part of the problem? And this was a nice little study. I, of course, I should be hesitant when I comment on this in front of Dr. Birnie, so you can correct me if I'm wrong. But they essentially looked at PVC burden in relation to the timing of corticosteroids. And this was done in patients who underwent device implantation so they could count the PVCs. They had a period prior to the initiation of corticosteroids. Then they had the period during which it was initiated, and then they had the period after it was sort of in place for an extended period of time. And it was pretty interesting. So before steroids were initiated, the burden of PVCs was much lower than after the initiation of corticosteroids. And you can imagine a number of ways where corticosteroids could be problematic for patients who are predisposed to ventricular arrhythmias. One is it increases blood pressure, increases glucose. It definitely has some effects on patients in terms of their mental well-being. It can be very stimulating to a number of patients in that way and raise anxiety levels, which may have a role in ventricular arrhythmia management. But this really raises a lot of questions about is the treatment in this case worse than the disease, and should we be thinking about other ways to try to suppress arrhythmias or the arrhythmogenesis than corticosteroids? Now, this is a really challenging topic, which Dr. Birnie is approaching with an ongoing clinical trial, trying to look at other treatment algorithms. But this is really one of the interesting pieces of data that lead us to question what to do with patients who have ongoing inflammation and ventricular arrhythmias. So now that I've presented a lot of data that is, I'll say, thought-provoking, but not necessarily definitive, there is some data to sort of say, well, how did different approaches come along? So here's sort of a nice study of 37 patients who had sarcoid and sustained VT. And the initial plan was to put patients on antiarrhythmics, and if they needed it, corticosteroids, and then they were followed. And then they looked, and within this group, okay, 23 did not have recurrence of sustained VT. They continued them on their regimen. And then in the 14 patients, roughly a third, who had recurrence of VT, they brought them for catheter ablation, and then they followed them, and they did reasonably well. So 8 of the 14 had no recurrence, 6 had recurrence. So with this strategy, there was a dramatic reduction in recurrence of ventricular tachycardia. So for many patients, this is a first go and a reasonable first go of how to manage them, particularly in those who may have ongoing inflammation. All right. And then they looked at recurrence, basically predictors, which was somewhat useful, but we're going to skip that. So I'm just going to summarize a few little points that we've gotten to at this point, right? So with patients with ongoing inflammation treated with antiarrhythmics and immunosuppression, in general, they do well. Patients without inflammation in general and are treated with ablation also do extremely well. But the comparison of what to do between these two groups is limited. And why is this relevant? Well, in a number of other studies of ventricular tachycardia and other clinical scenarios, VT ablation has been shown to have a lot of benefits for patients compared to medical therapy in terms of, so here's a very nice, basically retrospective study that shows they have fewer recurrences long-term, they have fewer episodes of VT storm, they have fewer hospitalizations, and they tend to, if you combine them all, they have a significant improvement in outcomes. So there is data to suggest head-to-head compared to antiarrhythmics, in general, patients do better with ablation. This is followed up and confirmed in another study, essentially. So keeping a little eye on time. And then there was most recently this Partita study, which was an ischemic group and showed that if you just treated patients after their first shock, they had an improved survival with ablation. So there is this background notion that in general, patients will do better with VT ablation when compared head-to-head with antiarrhythmics. So we still have to try to answer this question. In particular for patients with cardiac sarcoidosis, one way to try and get this answer is using basically very large cohorts of data. It would be great in abstract if you could have a clinical trial comparing these two groups. That is a very hard thing to pull off in this patient population because of the number of patients, and to some degree, it will be very challenging to enroll. But one group that tried to look at this looked at the national inpatient sample. They looked at patients who were admitted for ventricular tachycardia with a diagnosis of cardiac sarcoidosis. They looked at those treated with medical therapy and compared them to VT ablation. And they showed a trend basically towards a reduction in in-hospital mortality, although not clinically significant. Again, these numbers are relatively small. The length of stay was roughly equivalent. The cost was certainly higher with catheter ablation. That should not be surprising. But it certainly raises some questions. If you're starting to have a trend towards this degree of reduction in hospital mortality, that's not nothing. And then I started to look at this with Dr. Michael Gurn, who's an EP fellow now down at the University of Pennsylvania in the National Readmission Database. We looked at basically catheter ablation and compared it to medical therapy, but we also looked at this concept of elective versus non-elective catheter ablation. We looked at a number of different outcomes, essentially, and if you look at a composite outcome of mortality, cardiac arrest, or cardiogenic shock, if you compare medical management to catheter ablation, there's a trend towards improvement in this group. But if you subselect this down, the patients who came in for elective VT ablation in general did better than those who were managed medically. So it raises an interesting question about how do we get patients to elective catheter ablation, which is not always so easy. Readmission rates were not significantly different, but it raises this important question of how do we handle the acutely inflamed patient? And I'm hopeful that we'll start to be able to look at some data in some other databases that say people come up with a strategy quiet the patient down, see if you can get them quiet for a month or two, get their disease under control, and then consider VT ablation. In summary, I think there are a couple topics that we covered. So, one thing that we covered is what are the prognostic markers for patients with cardiac sarcoid of not doing well? So ejection fraction and heart failure, as we discussed, but also it's really important to recognize the ventricular tachycardia is a significant predictor of adverse outcomes and poor survival for these patients. How does inflammation affect VT ablation outcomes, I think, is another thing that we talked about. And it's important to realize that basically antiarrhythmics and anti-inflammatory therapy has increased efficacy to prevent VT in the acute inflammatory state in comparison to VT patients without ongoing inflammation. So these patients tend to not do great if you just treat them with VT ablation alone. And it's important to recognize that in patients who do not have ongoing inflammation, ablation likely has an improved outcome. There are no clear head-to-head comparisons of medical management versus ablation. And in terms of tools to guide management, basically, there may be an opportunity for these patients to try and get them under control after their acute episode and bring them for an elective VT ablation approach. But we need much, much more data in this area to help us try to figure out how to manage these patients. And with that, I'm going to say thank you very much for your attention.
Well, thanks so much, Tony, for that masterful talk. And obviously, the floor is open for discussion here. So, Tony, I'll start off by asking you a question, if you don't mind. And I always struggle with this, so I don't know how it is over there, but we live in Canada where resources are limited and access to PET scanners are not widely available. And so, the common scenario is, the patient has VT, has cardiac sarcoidosis. They previously were treated for it, let's say, and they present with monomorphic VT, right? And then my EP colleagues always want a PET scan before they decide on what to do, because their first concern is this sarcoid reactivation? Is there active inflammation, or is it scar-mediated VT? What's your approach in that scenario?
Well, I think getting a look at the VT, if you can, really helps significantly, and understanding it in the context of how they initially presented. Right. So if you have a patient who presented, let's say, a year or before with sustained monomorphic VT, and then you sent them out on an antiarrhythmic, and they come back with sustained monomorphic VT at a slower cycle length on amiodarone, there's a high probability that it is reentry related to the scar sort of maturing. Now, that does not mean not to do a PET scan if you can get it. Like, I would never say don't do it. But I think you're right. They're not always readily available. Of course, you want to look for other signs of inflammation, when you speak with the patient, right? So I never want to, you should always examine these patients. You'll find lymph nodes sometimes in these patients, and you'll be like, well, where did this come from? Or why do you have a rash at this moment? So if you can pick up inflammation on your physical exam, you should take it, and that might push you more towards PET scan. There's also some data on basically using gallium for some patients. If you're in a limited clinical scenario where you can't get a PET scan, it's definitely not as good, but it is a way to sort of look. But it really starts with understanding the time course of the patient. If they've been under observation and well followed by a good team, it's usually, I would say it's much less common that they come back with an acute inflammatory event, at least in my clinical experience. Now, there have been some exceptions to that rule. I would never say that's not the case. Those patients have tended to come in extreme situations. Now, if the arrhythmia looks non-reentrant, then you really do have to raise your suspicion about inflammation, right? So if there's a lot of cycle length variability, if it's VF and not VT, then you've really got to ask yourself, am I missing a recurrent inflammatory event? So how's that for a really long and challenging answer to your question? But,
I love it. That's what I expected.
yeah, they're hard. I mean, they're just really hard things. I would also say, that's a real argument for baseline testing, right? You got to get baseline imaging done on these patients, because if you don't, then you never know what's happening. So, we have patients, and I think everybody does. They show up with an ICD, they had VT, no one's even entertain the diagnosis of cardiac sarcoid. You know, don't just sort of go with the flow, if you will. Go through the effort to say, look, at some point you should get that MRI. You got to get that PET scan. I know you're feeling good and you're out of the hospital, but just, beg and plead and get it done so that when they do have a problem, you can really be there for them.
All right, thank you. Tony, if you could stop sharing your screen so we can get ready for the next talk too.
Oh, okay. There we go.
And David, for the sake of time.
Carry on, Mustafa.
I was going to say, for the sake of time, maybe we should move on. I think we're already 10 minutes behind.
Yeah, no, I was going to make the suggestion, so maybe I can introduce the next speaker. Dr. Chetan Shenoy is a cardiologist and associate professor of medicine in cardiology at the University of Minnesota Medical School in Minneapolis, NIH-funded clinical researcher. His research focuses on the clinical application of cardiac MRI and improving the diagnosis and treatment of patients with cardiomyopathies. And I specifically invited Dr. Shenoy because he's got, in the last 2 years, he's published at least 2 papers that I'm aware of that's really making the field sit up and take notice and maybe think a different strategy or different way of thinking about risk stratification. I think they're very important advances. So looking forward to hearing your talk, Chetan.
Thanks, David. I'm delighted to be speaking in this symposium. So these are my disclosures. Both of them are unrelated to cardiac sarcoidosis. So I was asked to talk about prognostication in cardiac sarcoidosis. So what does this mean? What is prognostication? And as we all know, the main worry with cardiac sarcoidosis is sudden cardiac death. So I would argue that prognostication mainly means deciding which patients would benefit from an ICD. And heart failure is a concern too, but in some ways it's easier to predict heart failure using simpler measures such as EF and the presence of pulmonary hypertension. So I'll focus my talk mainly on deciding which patients would benefit from an ICD. And so the first paper I'll talk about is this paper, which was published now 1.5 years ago. And this is from the Finnish group. And they have really published seminal papers in the field. And this paper concluded by saying that all patients with cardiac sarcoidosis who present with clinical manifestations should be considered for an ICD implantation. So this is a large study. It's a nationwide study. They got patients from all over the country of Finland, 398 patients. They had hard outcomes, sudden death, ventricular arrhythmias, good follow-up. So it's really good in every way, and there is no reason to really question these findings. And so in conclusion, which patients would benefit from an ICD? I think the answer is all of them. So are we done here? And do I really need to talk about CMR? Well, let's see who these patients were. So the patients in the study were included based on the HRS criteria. So that's how they defined the patients. 48% had cardiac histology, 98% had LGE, and of those who had nuclear imaging, 92% had perfusion defect. The actual ICD implantation rate was 74%, and the 5-year rate of ventricular arrhythmia or sudden death was 24%. So clearly high risk, very high risk, and the argument that everyone should get an ICD is very, very convincing. Now let's look at a cardiac sarcoidosis cohort from another big center in the US, Johns Hopkins, and this is a paper published last year in the Journal of Cardiac Failure, where they talked about sex differences. And here also they used HRS criteria in about 83%, so practically all the people. Cardiac histology proof in 6%, LGE was in 72% of those who had CMRs, and PET perfusion defects in 58%. Their ICD implantation rate was 57%, and the 5-year rate of ventricular arrhythmia was lower at 18%. Now let's look at another center, and again, another prominent center in sarcoidosis, the Cleveland Clinic. Again, big numbers, recent paper published months ago in Europace. They also defined these patients with HRS criteria, histology proof in 12, LGE was present in 40%, perfusion defect in 43%, ICD implantation rate of 58%, and the 5-year rate of ventricular arrhythmia or sudden cardiac death was 11%. So we have 3 populations, large numbers, where they were all defined using the HRS criteria, and we have highly variable rates of ventricular arrhythmia and sudden death. So do we think all these patients should be getting an ICD? And these are papers that talk about the diagnostic criteria. The first one from Cleveland Clinic talks that the 3 diagnostic criteria do not encompass a high proportion of patients that they suspect to have cardiac sarcoidosis. The second paper from Germany, the title says it all, current diagnostic criteria show a substantial disagreement in classification of patients with suspected cardiac sarcoidosis. And this third one, published recently from the Cardiac Sarcoidosis Consortium, led by Jordana Krohn, they looked at all patients who met any one of the criteria, and they found that only 10% of patients really met all the criteria, and there was great variability in the number of patients who met one or the other criteria, as you can see in this Venn diagram. So I look at this as this old Indian tale of the blind man and an elephant. So these blind men are really feeling different parts of the elephant, and they're imagining what an elephant looks like. And I know I'm talking in David Birnie's Symposium, but I will say, I think what many will agree with, we are not really very good at identifying who really has cardiac sarcoidosis. And so this becomes the problem with applying the Finland criteria or the Finland findings. So a few years ago, we figured this out based on the referrals that we had that were looking like everything and anything. And so we decided we really need to learn what cardiac sarcoidosis looks like. So how do we do that? So we have to go to definitive cases or cases with cardiac biopsy-proven cardiac sarcoidosis, and so learn from their findings, ideally from CMRs, which would show the patterns of cardiac damage. But when we looked at our patients, those patients were very rare because we don't do a whole lot of EMBs. No one really does other than the Finland group. And those patients are rare. So the next step was to look for pathology studies. And so we looked in the literature, are there any pathology studies which tell us what cardiac sarcoidosis should look like? And there were no studies, but we found a number of case reports, and we found a lot of them. And we actually looked at all the images in these case reports, and we sort of analyzed the pictures ourselves and put together. And based on these images, we published this meta-analysis where we found that a number of features were very common, and a number of features are actually rare or never seen. And so the common ones being subepicardial, multifocal, septal, and RV free wall. And these were seen in over 90%, some of them in like virtually all the cases. And more interestingly, we found that there were some features which have been believed to also be cardiac sarcoidosis, but they were not really seen in this meta-analysis. So isolated mid-wall involvement, isolated subendocardial involvement, or the absence of complete involvement, we saw no cases with these features. And so we said, okay, so this is really helpful, and this is how the disease looks like. And this is a framework using which we can really diagnose this disease. And these are the images. These are all 49. We actually got permissions from all the case reports, the publishers, and we included them. So if you download the PDF, it's about 60 megabytes, but you'll be able to see all these images for yourself. But there was one problem with this conclusion. These were all patients who had died of sudden death, or they had transplant for advanced heart failure. So are these findings only representative of one end of the spectrum? So this is classic spectrum bias. Could we really use this to make a diagnosis and management decisions in people who are not really advanced? And so we wanted to look at this, and we looked at our CMR database. So this is the publication where we looked at 500 patients, and we looked at these patterns. And here, again, we don't have the gold standard definitive diagnosis of endomyocardial biopsy. So we said we'll look at the next best thing, which is long-term outcomes. And lo and behold, the features that we saw very common in the pathology analysis were associated with a very high risk of ventricular arrhythmias. And interestingly, all the other manifestations, so even if they had LGE or abnormal EF, they were associated with a really low or no occurrence of ventricular arrhythmias. And this also predicted the occurrence of heart failure, but the other phenotypes, since some of them had LV dysfunction and some of them had presumably some pathology going on, they also had lower levels of heart failure. And I recently updated our database for this talk, and we have more patients. We added 140 more patients, more events, and still we can see that patients who fit this pattern of what the features are frequently seen on pathology, which I call as pathology frequent LGE, these are the people who really have virtually all the events, ventricular arrhythmic or sudden cardiac death events. And the absence of this really portends an excellent outcome. And this is going on to 10 or 11 years. And this is the high-risk phenotype. These are not the same patients. So this is the example of a gross pathology picture of a patient with histology-proven cardiac sarcoidosis. And you can see the features that we saw often, involvement of the outer portion or epicardial, multifocal involvement, and you can see the enhancement of the right ventricular free wall. And for some reason, there is more involvement of the septum or septal predominant involvement in this disease. And so how does this phenotype compare with the finished data? So here, the advantage of this phenotype is that we don't really need to depend on the criteria, which, as I said, are quite subjective and variable. And this simply depends on LGE. And here in our cohort, the 5-year rate of ventricular arrhythmias was 33%. So 1 in 3 really had either sudden death or more often ventricular tachycardia or ventricular fibrillation, which was treated by their device. And what is more interesting and more important, I think, is absence of this phenotype. And we have 517 patients. Some of them have LGE, although not in the high-risk pattern. 15% LGE, 17% have abnormal EF. At 5 years, the risk of ventricular arrhythmia or sudden death is 0.8%, so less than 1%, very reassuring, and clearly a group that does not need ICDs. So this is the data which is sort of missing from the Finland group. They are very good at picking up the people who deserve ICDs, but we don't really know if the people that they did not include in the study, in their cohort, the people they deemed as not having cardiac sarcoidosis, we don't know how they do. but here we have data and sort of a control group. So in summary, I would say that this is a pathology-based, not simply expert opinion-based, and this is a visual, so there is no quantification. We are simply looking at the pattern of involvement, and it's a framework to identify sarcoidosis patients who would benefit from an ICD. It avoids the subjectiveness of the diagnostic criteria and only uses the LGE features. And more importantly, absence of this phenotype indicates a very low risk of sudden cardiac death. So I talked about diagnosis and prognosis. And so why does this phenotype really work so well? So I think, and this is my opinion, I think this phenotype indicates the people who truly have cardiac sarcoidosis. And the absence of the phenotype, even if they have some abnormalities, indicates those who don't. So they may have other cardiomyopathies, other reasons to have a low EF or maybe subendocardial MI, such as CAD or MINOCA. So I think the prognosis and diagnosis are two sides of the same coin. Here, I don't have data to prove that the people who don't have this high-risk phenotype don't have it, simply because I don't have data on cardiac biopsy proven or cardiac biopsy data on all these patients. But if this is true, then indeed, all patients with clinical cardiac sarcoidosis would benefit from an ICD. So sort of, I came full circle, and this is truly the end of my talk. Thank you.
Thank you so much, Chetan. We're a little bit behind time. Outstanding talk. I think that paper you published last year is probably one of the most important papers in the whole field in the last 10 years, in my humble opinion. I think it's a really groundbreaking paper. And we have time for one question, maybe. I see Dr. Patterson with his hand up.
That was outstanding, Chetan. Thank you for that talk. Yeah, as I was listening to your talk, I was thinking, what's important? Is it important to identify all of the patients or only the high-risk ones? And I think you've shown, really, and I was trying to think actually of cases of cardiac sarcoid that I've seen without enhancement, and I can't really think of any. So I would question, the diagnosis myself personally if I had a case that didn't have late enhancement. But my question for you, the case you showed towards the end there of the high-risk phenotype with the image, it looked an awful lot like arrhythmogenic cardiomyopathy. So could it be that some of these high-risk sarcoid cases that you're detecting that you don't have biopsy, or could they actually be other high-risk cardiomyopathies mixed in there? Like, do you have genetic information on any of these patients, or?
Yeah, not on this particular patient, but we are also very interested in arrhythmogenic, and we have a separate database of those people. And we are working on identifying the differences in the CMR patterns of these patients. And one of the findings, the easy findings, is that whenever the RV is involved in cardiac sarcoidosis, it tends to be sort of focal. So we will find areas of the RV free wall which are not involved, whereas with arrhythmogenic cardiomyopathy, we tend to find that the whole wall is involved if we can see it. I mean, it's not always that we can see RV LGE, but if we do see it in genetic cardiomyopathies, we think that the whole RV wall is involved, and that's the advanced cases. Whereas it's a little easier to see in these patients, and it's focal, and I think it's because of acute inflammation and edema, making the RV free wall a bit thicker and making it easier for us to identify RV free wall LGE. There are also other findings on the patterns, the presence and absence of fat. So fat is something that we see with genetic cardiomyopathy, but we don't see intramyocardial fat in cardiac sarcoidosis. And the LGE tends to be more lateral predominant and more apical in the genetic cardiomyopathies, whereas it's more septal in the cardiac sarcoidosis. So there are some features, and we have at least 2 cases of patients with genetic cardiomyopathies who have histology-proven sarcoidosis from their lungs. One of them had a FLNC dilated cardiomyopathy.
Thank you. We're going to. I know I see other hands up, but I'm afraid we're a little bit behind time, so we're going to have to move on. Are you going to? Let me just see, because it's me next. I hope you're seeing my slides now. Mustafa, can you see them?
I do not. I just still the same.
Okay. Blah, blah, blah.
Now, David needs no introduction, of course. He's one of the key opinion leaders in Canada and really in the world when it comes to cardiac sarcoidosis. And he's, of course, co-led the guidelines, the heart rhythm guidelines from 2014. And I think that hopefully 2024 upcoming guidelines as well. And he's been instrumental in getting not just Canadians, but the people from all over the world to come together to diagnose and treat this condition better. And I'm so glad that he's going to be talking about a very challenging part of cardiac sarcoidosis that I still don't know what to do with, which is what is isolated cardiac sarcoidosis and what do we do with it? And hopefully David knows everything about it and he'll teach us today.
Yeah. Are you seeing my slides now, Mustafa?
Yes, I do.
Okay. So thank you for that introduction. And, really, this is a very controversial area in the debate. It's really on 2 levels. Sarcoidosis is by definition in biology a systemic disease. So really the debate is whether there's a sarcoidosis-like disease that only involves the heart. So I wanted, first of all, to talk about what a reasonable definition might be and whether the entity even exists. So this is what the literature says when you look at it. The prevalence of isolated cardiac sarcoidosis in literature is reported to be between 3 and 54%. Why is there such a range? And my thinking on this is there's likely 3 main reasons, and the diagnostic method for assessing extracardiac involvement is probably key. If you don't look very hard, you're not going to see other organ involvement. The second issue is the overreading of cardiac PET scans, which is really a big problem. And the third issue is the lack of an agreed definition of isolated cardiac sarcoidosis. So the overreading of PET scans, this is really very important. And, it's very important that you have good, if you're going to really take on cardiac sarcoidosis as a special interest, it's really important that you've got good imaging. And the key to this is the suppression or the dietary preparation before the PET scan. If the dietary preparation is not done properly by the patient, you're going to get false positive scans. And, the false positive scans look absolutely the same as cardiac sarcoidosis. Look at this. His heart looks like it's on fire, but this is actually a patient that doesn't have cardiac sarcoidosis, just has partial suppression of glucose utilization. And just to show you how big a problem this is unpublished data that we're hopefully going to publish soon. So we looked at this in Ontario, and what we did was we first of all got the centres to send us their PET scans. We then got them to send us their PET scan reports. We then independently read their PET scans and also independently read their PET scan reports and put it all together. So if I start you along here, there was 22 patients out of 140 where we agreed, our centre agreed with the local report there was active cardiac sarcoidosis. But look at this over here. There was 40% of the patients that we felt the other centres had overread active cardiac sarcoidosis. So more patients had an overread. That's not to say we necessarily were the gold standard, but we did have more experience than the other centres. But it's a substantial problem. It's definitely getting much better out there in the community as the education efforts have been ongoing. So how should isolated cardiac sarcoidosis be defined? So the Japanese, are leaders in this world, and they've actually just most recently, they've produced the world's first diagnostic guideline for isolated cardiac sarcoidosis. And as Mustafa mentioned, the Heart Rhythm Society have just started the process of updating their 2014 guidelines, and we'll also, in our document, be tackling this issue. But the bottom line is, for their definition, they said, you had to have no clinical findings of sarcoidosis anywhere else than in the heart. Also, a PET scan or a gallium scan should show no abnormal tracer accumulation in any organs other than the heart. And also a chest CT scan should show no lymphadenopathy. So using this definition, what are the data? This is a paper from our group where we used a very similar definition to the Japanese one. We were working on this simultaneously with the Japanese guidelines. And we defined isolated cardiac sarcoidosis as patients having no evidence of FDG uptake in whole body PET scan, no evidence of skin sarcoidosis or eye sarcoidosis when they were clinically examined. And we looked at 31 consecutive patients, and we only found one patient out of 31 that truly had what would seem to be a definition of isolated cardiac sarcoidosis. The other thing that this study taught us was that, these patients who present with cardiac sarcoidosis also usually have very minimal organ involvement elsewhere. For example, in medical school, we're always taught that, sarcoidosis involves the lungs in 95% of patients. But if you look on this row here, we found that the lung involvement was only about 45 and 55% in this cohort who presented with cardiac sarcoidosis. So we found that 1 out of 33 patients had apparent clinical and imaging isolated cardiac sarcoidosis. So does that patient truly have isolated cardiac sarcoidosis? And I would argue no, and I would present two arguments. And the first argument is that sarcoidosis is a dynamic disease. And we also know that FDG PET imaging has limitations, including spatial resolution. So it's also clear that FDG PET detectable inflammation seems to have different time courses in different tissues. And I'll show you one case that makes this point. So this is a patient who we know had active cardiac sarcoidosis. This is the initial presentation in January 2016 with high lymphadenopathy, also involvement in the heart. This is after a period of treatment. And then what we did in this particular patient was we actually withdrew treatment, and then there was a flare-up of disease just in the heart. And then later on, reinitiation of treatment, and there was no active disease anywhere. So there does seem to be different time courses in different organs. And sometimes just at the moment that you're imaging, it does appear that only the heart is involved. So the second argument, comes from a couple of papers where they took patients that would appear to have isolated cardiac sarcoidosis. This is one paper from Patak et al. They took patients with presentations in cardiac imaging consistent with cardiac sarcoidosis, but nothing on a whole body PET scan and nothing on a CT thorax. It's actually only 8 of them had FDG PET scans. And 10 of them went on to have biopsies. And 4 of them, so these were just somewhat blind biopsies of the lymph nodes in the lungs. And 4 of them had granulomas, again, making the point if, it just may be an imaging spatial resolution thing. If you look elsewhere, you usually find disease elsewhere. And my final point is, the FDG PET scan appearance of possible imaging isolated cardiac sarcoidosis is usually something else. And that's why the debate is so clinically relevant. And I'll show you a few points. So this is the ultimate proof where you get Chetan's type of data, where you get an explanted heart and you cut it up and you look for granulomas and you look for scarring. So this is a study where they had 3 patients that they were absolutely convinced had isolated cardiac sarcoidosis. They treated them with immunosuppression. The patient went on to transplantation, and they found that all 3 patients did not have cardiac sarcoidosis. And there are other things that look like cardiac sarcoidosis on PET scan imaging. This is a patient with myocarditis on PET scan imaging. This is what giant cell myocarditis looks like on PET scan imaging. So it looks very much like isolated cardiac sarcoidosis. Nothing on the whole body PET scan, but this patient actually had giant cell myocarditis. This is a paper suggesting that ARVC can also look a bit like cardiac sarcoidosis, isolated cardiac sarcoidosis in some patients. This is a patient who turned out to have myocarditis secondary to Crohn's disease, and looks a bit like isolated cardiac sarcoidosis. And this is a patient with a lymphoma in the septum that looks a bit like isolated cardiac sarcoidosis. So I'll finish there with my thoughts. I think clinically isolated cardiac sarcoidosis is very common, and I think one of the first things that we have to agree on in the field is to speak the same language. So when we're saying isolated cardiac sarcoidosis, are we saying clinically isolated cardiac sarcoidosis, or are we saying clinically and imaging isolated cardiac sarcoidosis? So clinically isolated cardiac sarcoidosis is common. Clinically isolated cardiac sarcoidosis has a worse prognosis than non-isolated cardiac sarcoidosis, and we know that. And that's because it presents with cardiac manifestations, whereas a lot of non-isolated cardiac sarcoidosis is often picked up incidentally when you screen other forms of sarcoidosis. Clinically and imaging isolated cardiac sarcoidosis is very rare. If you see a patient with possible clinically and imaging isolated cardiac sarcoidosis, then pause and make really sure of your diagnosis, because you may be missing other diagnoses. And I believe that there's really no evidence at the moment to support truly isolated cardiac sarcoidosis.
Oh, David, thanks so much. I would argue provocative conclusion. Tough, and tough to convince my EP colleagues sometimes. But Peter Sporn has a question. You can maybe unmute yourself, Peter.
Hi, sorry about that. Yeah, I was having difficulty with the unmute. I'm maybe one of the few or maybe the only non-cardiologist on the call. I'm a pulmonologist at Northwestern in Chicago. And so I like the argument that isolated cardiac sarcoidosis either doesn't exist, as Dr. Birnie suggests, or is uncommon, but that this is certainly a dynamic disease. And as a pulmonologist, I would argue similarly that sarcoidosis isolated to the lung alone is also a rather uncommon entity. And, we are the nexus for all sarcoidosis at my institution. So we catalog all the organ system involvement in each of our cases. And we have a very large cardiac cohort. But I do want to make this point with regards to the findings on explants of patients who've undergone heart transplant. I have 2 patients who had biopsy-proven cardiac sarcoidosis who later went on to transplant. One was an endomyocardial biopsy-proven case. The other was a patient who had an LVAD where the plug showed extensive granulomas. And at a later time point, a year or 2 later in each case, they went to transplant, and the explants in both of those cases showed no granulomas, just dense fibrosis throughout the entire myocardium. So I don't say that to try to contradict anything that Dr. Birnie said, but I think that is a valuable point. This disease can evolve from extensive granulomatous inflammation to pure fibrosis.
No, absolutely. Tony?
Yeah, this talk I think was provocative, and I guess in light of your systematic review of PET scans and some of the other data you presented, I would question, should we be having a systematic review of CT scans for lymphadenopathy? Now, maybe Dr. Spore wants to talk about this as the pulmonologist in the room, but part of this problem may be just how do we even define extracardiac and all these other ways that we assess it? What are our other study qualities?
David, I don't know if you want to answer that. I have another question, so I'll hold off on my question for you.
Yeah, I agree with the comment. I think that there's a lot of dogma in the field of cardiac sarcoidosis, and I think it's very important to always challenge the dogma, and that's maybe one part of it. And it's also confused by the fact that I actually didn't know this until I was reading about this, that it's quite well described that heart failure can cause mediastinal lymphadenopathy in itself, which I didn't know until I read a bit more. So
yeah. So I'll tell you this, David, as like earlier on at 1:05 p.m. when this conference started, my colleague emailed me, 58-year-old lady, pre-syncope, high degree AV block, dual chamber pacemaker, EF 50%, extensive LGE on MRI, and a positive PET scan, biopsy negative. Would you treat or not treat? That was a question to me. So truly isolated cardiac sarcoid, based on the definitions you have given us, young lady with AV block. I mean, it's so hard, right? I mean, the EP guys are already upgrading her to a CRTD, and my feeling is we should treat her. Now, is it because it's a dynamic disease and we haven't found the active lymph nodes or FDG avidity elsewhere in the body on the PET scan, or is this truly isolated cardiac sarcoidosis that you don't believe in anymore?
Well, it all depends on what you mean by a positive PET scan, Mustafa. Is it a positive cardiac PET scan,
Yeah.
or is it a positive whole body PET scan, or is it?
It's a full body with only heterogeneous intense uptake throughout the myocardium.
Yeah, I would not treat that patient. I think but I would not lose sight of further evaluation. I would perhaps repeat the PET scan again and actually measure ketones at the moment of the PET scan just to make sure that there's adequate diet. Depression. And the other thing I would do is, the other thing I would do, I would be very cautious. I would definitely do an EMB, a guided EMB in that patient. There's also, a form of false positive PET scan that still has to be described. And I've seen this a few times now. Patients with extensive LGE for whatever cause have abnormal FDG uptake. And I think it's because their myocardium is also screwed up with their extensive LGE, that the residual myocardium has abnormal FDG uptake. So, I have to prove that, but I've seen it a number of times now. But that
So I was going to say the other thing we must not forget is the genetic inflammatory cardiomyopathies that I think there's a paper published in JACC last year where about a third of patients with isolated cardiac sarcoidosis, when they had genetic testing, had an inflammatory cardiomyopathy gene mutation.
And that's a perfect, we're again a little bit behind. That's a perfect lead into we've got two case presentations, and I'm going to introduce both of them. One is actually exactly presenting a case like that, Mustafa. The patient ended up, I'm giving the answer away, so I won't. So I'm going to ask I'm going to mess this name up, Dr. Rochlani, to maybe share her screen, and she volunteered to present a case for us. Are you able to share your screen?
Yeah, thank you, Dr. Birnie. Thank you for having me here, and I'm excited to present this case. And hear what everybody has to say. It's kind of a clinical conundrum, very much like what you just described, Dr. Toma. And I'd love to get, advice from more experts here as to how to take care of this patient. So I'll share my screen. I'll switch it to presenter view.
Sorry, I didn't introduce you properly. I met Dr. Rochlani virtually about 3 years ago when she contacted me. Was very interested to join our clinical trial in cardiac sarcoidosis. She works in the Bronx at Montefiore Medical Center. Our clinical and our research focuses on cardiac sarcoidosis, myocarditis, cardiac transplantation, and mechanical circulatory support. So thank you for agreeing to present the case.
Thank you. Thank you for having me again. So let's go over this case. The discussion again is, isolated cardiac sarcoid versus arrhythmogenic cardiomyopathy. This is a patient who I follow in my clinic who saw me maybe 4 or 5 months ago, and I'll just go over his story a little bit. So this is a 57-year-old Caucasian man who was referred to the cardiac sarcoidosis clinic here at Montefiore. He's had, his symptoms really at presentation were palpitations, dyspnea on exertion, dizziness, which has been going on for several years now. And, it's been fluctuating, but, he seems to be more symptomatic over the past 6 months or so. He's had a history of atrial fibrillation, episodes of atrial tachycardia, non-sustained VT. And on his most recent Zio patch before he came to see me, he had a PVC burden of about 5%. His LV function has been fluctuating anywhere between 40 and 50, like in the mildly reduced range for the last several years. This is his medical history. So he's basically, has hypertension, diabetes, where his A1C has ranged between 7 and 10, depending on how well he takes his meds. Obesity, his BMI is 35, has sleep apnea. And these are the medications that he's currently on, which is basically heart failure therapy given the fluctuating EF. In addition to the usual hypertension, diabetes, obesity, he does have a history of these arrhythmias that have been going on for at least 10 years now. He's been followed by our EP group for this. And he does not have a personal history of sarcoidosis anywhere else in the body that was diagnosed, does not have a family history of sarcoidosis, and does not have any history of exposure to the whole World Trade Center episode here in New York, which, sometimes we see that correlation. Labs of note, his A1C is now under good control. His ACE level is normal. Soluble IL-2 receptor level was normal. Vitamin D level, calcium is normal. CRP is okay. ESR is mildly elevated. So this is his initial cardiac testing as he, that he's had. This is his EKG. I know there are a bunch of electrophysiologists in the room here, but just to make it very simple for everybody else who's not an electrophysiologist, he's actually in sinus rhythm, has first-degree AV block. And then he interestingly has these episodes of bursts of atrial tachycardia, which become irregular. And this has been going on for several years on several EKGs. But that's really the most remarkable part of the EKG. Echo, here you see that, that it's poor quality. He's kind of obese. It's difficult to get great images, so you don't see good endocardial borders. But basically, EF is not terrible. It's mildly reduced. So moving on. So let me just tell you a little bit, as I saw him for the first time, I dug a little bit into his chart to see what had really been going on and what prompted this referral to the cardiac sarcoidosis clinic at this point. So it looks like he initially presented 12 years ago, again, with similar symptoms of palpitations, dizziness, pre-syncope. And even at that time, based on the Holter monitoring that he'd had and the EKGs, he had a bunch of arrhythmias, atrial arrhythmias, non-sustained VT. At that point, because he was first presenting with all of this, he had an ischemic workup that was negative. He had an exercise stress test where the arrhythmias did not get worse. He had a cardiac MRI at that time. And there was some question, this was 12 years ago, I don't have access to the images, but there was some question of non-compaction, which was essentially by consensus thought that it was not non-compaction, but he did not have any LGE and normal biventricular function on the MRI at the time. He did have a lot of RVOT PVCs, so he eventually underwent ablation for the RVOT PVCs at that time. Between 2013 and 2020, after the PVC ablation, he was on antiarrhythmics, beta blockers, continued to have these atrial arrhythmias. He had 2 AFib ablations in 2019. Basically, he had pulmonary vein isolation, SVC isolation, coronary sinus isolation, and despite that, continued to have AFib, so refractory AFib. And his EF until this point for a good 7-8 years had been relatively okay, 55%. So it was mostly the arrhythmias that were a problem. Fast forward to 2023, continues to have palpitations, continues to have these arrhythmias, but now is more symptomatic. So he has more dyspnea. His EF is now 40%, has some regional wall motion abnormalities, and has more Holter studies at this point to look for the arrhythmia burden that show that he has lots and lots of like atrial arrhythmias, ventricular extra beats, but nothing sustained. So at this point, I guess, the concern was, is this cardiac sarcoidosis that we've missed for all these years, that he's continues to have these arrhythmias, and now he's starting to see a decline in his EF. So we repeat an MRI at this point, or his cardiologist who was seeing him repeats an MRI. And here is what we have on the MRI. So his EF is, compared to the echo, now between the echo and the MRI, there's some period of time he's gotten some GDMT. And his EF on the MRI looks a little bit better. I apologize for, that wasn't the best study, so I apologize for what the images look like. But essentially, the gist of the MRI is LV function is not so bad. He does have areas of fibrosis and scar. He has some areas in the septum, mostly in the lateral wall. I think the third LGE image is the, at the mid-level of the short axis is the best image, where you see a bunch of scar in the lateral wall and then patchy scar, mid-myocardial, subepicardial scar in the septum as well. So, with all of that, the next step, of course, is he was referred for a PET scan because that MRI was read as suspicious for cardiac sarcoidosis given the patchy LGE and the arrhythmias. On the PET scan, he has no extra cardiac uptake anywhere. Unfortunately, this is not a whole body PET scan because this is just the thorax, because we have challenges getting whole body scans based on insurance and things like that. So this is just the thorax, but no extra cardiac uptake, only uptake in the heart. And here he has uptake in the lateral wall, somewhat in the right atrium, and in the basal anterior wall. He also has, of note, normal perfusion on the scan. So just FTG uptake, normal perfusion. At this point, his cardiologist concluded that this is extremely suspicious for an inflammatory cardiomyopathy like sarcoid. He gets an ICD implant, EF is 40%, has a positive MRI, positive PET scan with 15% LGE burden. He is on GDMT, and he was started on prednisone 40 and referred to the cardiac sarcoidosis clinic for further management. So, I just want to stop here for a second and ask the panel a question. Would you treat this patient with immunosuppression? I think this is very much like the 58-year-old lady that you just mentioned. Do we have a diagnosis? And should we start treatment, or do we need additional workup? Now, based on the HRS criteria, we do not have a diagnosis, but based on the isolated cardiac sarcoid Japanese criteria, I think, this would meet criteria for isolated cardiac sarcoid. So what does the panel think at this point?
Do you mind if I go first?
Absolutely not.
Oh, go ahead. Yep.
All right. So my name is Paco Bravo. I'm faculty at the University of Pennsylvania, and I read both cardiac PET and MRIs. And what I would say is that the FTG uptake in this particular patient limited to the lateral wall is extremely common in patients who have incomplete suppression. And it's one of those patterns that many years ago, people would just, any uptake in the heart would be called positive. But as we've been learning more and more about the different patterns of incomplete suppression, we realize that this is one of the most common patterns of incomplete suppression. So in situations like this, we call it non-specific, and we recommend to repeat the scan with a longer prep. So we have lots of examples of patients with uptake limited to the lateral wall that follow the diet for 1 day, and then they come back after following the ketogenic diet for 3 days, and the uptake is gone. So that's that. So in my mind, this uptake in the lateral wall is physiologic until proven otherwise. And is Chetan with us? He can comment on the MRI better than me, but the LG pattern is not what we would call, typical for sarcoidosis. I don't know, Chetan, you want to comment on that?
Yeah, so I think the LV function looked a little worse than what was quantified. It looked more 40-ish to me, and a few distinguishing differences between genetic versus cardiac sarcoidosis. So at first glance here, it looks like there is septal involvement, multifocal involvement, and even maybe epicardial involvement. But the LV dysfunction seems out of proportion to the areas of involvement. And cardiac sarcoidosis actually is more like an MI, where the areas that do not have LGE almost always have normal contractility. So the extent of LV dysfunction is kind of proportional to the extent of myocardial damage as we see on LGE. So that's one thing that argues against this being cardiac sarcoidosis here, even though there may be multifocal septal involvement. And then the 12-year odyssey, the presence of LV non-compaction, I think all these also point towards this being more likely a genetic cardiomyopathy rather than cardiac sarcoidosis.
Thank you. And the other thing I wanted to comment on is when you're reading these things, the location of late gadolinium enhancement and FDG uptake should match most of the times. There's actually an excellent spatial colocalization of the location of LG and FDG. And if you notice in this case, most of the LG is kind of in the septum, and there was no FDG uptake in the septum on PET. I'm sorry, FDG uptake on the septum. It's in the lateral wall. So there's also discrepancy in the location of FDG and LG.
Yeah, actually, interestingly there, I did discuss it with our imaging folks when we got these studies, and their take was usually, the isolated lateral wall uptake is considered to be a normal variant. Even here, they would not make much of it, but because there was LGE in the lateral wall as well as FDG uptake in the lateral wall, there was concern that this might have been something real, and that's why the decision to kind of treat. But we did some more workup. So he, after he came over to see us.
Yogita, we're a little bit behind time,
Yeah.
and we've got one more case. Could you just go to maybe your final couple slides?
Yeah.
Sorry,
of course.
Because it's a great case, and I hate to rush you, but
Yeah, sure. So, basically we did a bunch of workup to rule out extracardiac disease. We did send a genetic panel like we do for all of our isolated cardiac sarcoid patients. And this gentleman had a calcium channel mutation, which has, there's some case reports. He did have a repeat PET after a few months of therapy, which looks a little bit better, still has some isolated lateral wall uptake. And this is essentially the mutation that is extremely rare, but has been described in a few cases as what is called cardiac-only Timothy syndrome, which might be, it's a calcium channel, it's a gene that encodes the calcium channel that can present with basically hypertrophic cardiomyopathy, long QT, or maybe arrhythmogenic cardiomyopathy as well. So essentially, the question here is, what do we do with this gentleman now? Should you stop his immunosuppression? Is this enough to say that this is not inflammatory? Should you immunosuppress even if it is not sarcoid, some other type of inflammation? And then how do you manage his arrhythmias? I think what's really making him symptomatic is the arrhythmias, but he has refractory atrial arrhythmias that we haven't been able to control. So does anybody have any ideas for how we would manage that?
Yeah, no, I would. I personally would stop his immunosuppression and not repeat his PET scan. I think, yeah. Go ahead,
I
Pablo.
agree. I agree. I'm laughing because I totally agree.
Yeah, I would agree with that. I would also add, did you say that there was PET positivity in the atrium? I mean, that's uncommon. And I would love to see some more data on this, but the cases where I've seen of atrial involvement where I'm convinced it's sarcoid, they have bad atrial myopathies, not, like an AT, a spazzy little AT. On the other hand, I have seen misdiagnoses of sarcoid that have later turned out to be genetic or some other type of disease with PET positivity in the atrium. And I'd be curious, I don't know the data too well on this quantification of atrial positivity of PET and what's out there, but that is always suspicious to me when you see the atrium really positive. It's something doesn't quite fit. I don't know if other people have any experience with this.
Yeah, your point's well made, and there is a little bit of data emerging about atrial FTG uptake, and it does increase your risk of arrhythmias in cardiac sarcoidosis. But he's also had 2 AF ablations. I wonder if some of it is. I'm not sure the chronology of the AF ablations relative to the PET scan, whether it's still some residual information. There's also a little bit of data that maybe even atrial arrhythmias in themselves, regardless of whether they have cardiac sarcoidosis, can in themselves lead to abnormal FTG uptake in the atria. So I would be less worried about that. I'm very compelled by the fact that it's lateral wall uptake consistently, which is, quite well described as a false positive.
Yeah, it's interesting actually what Dr. Shenoy was saying earlier about the apex being spared on MRI, because I think this false positive, you'll often see it going down to the apex. So I was wondering, how do you reconcile those two pieces of information? You get all these PETs that have positivity at the apex, supposedly, and then you can't find a real case of cardiac sarcoid that has any LGE to go with it or scar. Something doesn't fit, and this would be a classic case of that. That false inflammation down the apex never really correlated with a disease state.